Hello, my name is NETO ROSATELLI and welcome to the Cataract surgery channel. This commented surgery is a cataract surgery done in a pseudoexfoliation patient that, by an unexpected twist of fate at the time of IOL implantation, turns into an interesting case to be brought here. After OVD on the cornea, you can appreciate the typical appearance of a pseudoexfoliation case with gray-white fibrillary material deposited on the lens capsule periphery. The good pupil dilation obtained is a good omen though, suggesting a mild form of the condition, of which the zonular compromise is the most challenging. Side port and main incisions are made, followed by 0.5% lidocaine injection and dispersive OVD. The engraved Inamura forceps markings confirms good dilation size, and capsulorhexis is performed in a routine manner. Importance of a good-sized rhexis is made greater here, should the zonular compromise be significant enough to call for a capsular tension ring or even a sulcus-placed IOL with optic capture. Very satisfactory hydrodissection and hydrodelineation are performed, and hint of a golden ring can be seen at the pupil margin. The incision adjacent conjunctiva is open to avoid ballooning. Anterior cortical matter is aspirated. It is a soft nucleus, and I approach with a stop-and-chop trench to gain space and be able to easily work the nucleus pieces. This is a transverse chopping, and more mechanical fracturing follows. The pieces are then readily emulsified. The epinucleus is already loose from the previous maneuvers and easy to deal. A lot of cortex remains, and being a relatively small pupil case with probably some zonular issues, I go conservative and opt for a coaxial IA cortex management. Grabbing the cortex tags at the rhexis margins makes for a very easy and safe technique, and also very efficient. Luckily, there seems to be no significant zonular compromise. The fibrillary deposited material can now be seen on the anterior capsule once the cortex has been removed. I use the chopper now to push the pupil margin around and check for any hidden cortex remnant. Since I was able to easily get all the cortex out with no assistance, I do this maneuver only now because iris touch could provoke meiosis and interfere with an easy cortical cleanup. There is nothing left but some central posterior capsule fibrosis, which I don't mess up with, to avoid detaching some zonules. Sometimes we can spot in advance a lost battle. IOL time and a potentially challenging surgery is tame. IOL hydroimplantation is done. And what? What is that in the IOL? I fill the eye a little more to enhance visualization, and I can tell there is some matter on the posterior face of the IOL, but I can't be sure. Maybe glove powder? I opt for safety and decide to exchange the IOL. I fill the anterior chamber with OVD and prolapse the proximal haptics out of the bag. My IOL micro scissors are broken and I haven't replaced them yet, so I'll have to resort to a regular corneal scissors that, despite being thin, are cumbersome to that task. Fear of endothelial damage is great, and that's the reason I leave the distal haptics of the IOL still in the bag, to have more anterior chamber room and be able to insert the scissors at a steeper angle. I enlarge the incision a bit to facilitate IOL cutting and extraction. Had I prolapsed the IOL completely in the anterior chamber, it would be very crowded. Next step is to prolapse one of the proximal haptics from the incision and secure the IOL while the scissors are inserted to make a cut halfway through the IOL optic. The haptic breaks, but the scissors are already in place and I'm able to cut the IOL rather nicely. This is a very cumbersome maneuver. Now I can extract the IOL by pivoting it in its center in the incision. I'm satisfied that it was a very atraumatic extraction. Boo! Eyewash! Sorry, I couldn't resist that. Even I got a scare when I was editing this video. This surgery is a few months old and I didn't remember that. Substitute IOL is implanted and carefully tucked into the capsular bag. Some would prefer to first implant the substituting IOL first and protect the posterior capsule from the maneuvers, and then extract the offending one. Yeah, this IOL is okay, and it seems like the zonules are in order too. OVD is thoroughly aspirated and things are almost done. The enlarged incision must be closed for safety. Tanno nylon suturing is done. I like this X-fashion stitch to close incisions, with relatively long throws to facilitate adjusting and rotation of the knot. Intracameral antibiotic and corticosteroid medication is injected and incision sealed. Mind that this was all done under topical anesthesia, and I was lucky that the patient was very cooperative. I wish you luck with your pseudoexfoliation cases. Search NETO ROSATELLI on YouTube or click on the link below and visit my other channel with Cataract Phaco Clips. Please like, share, subscribe and turn notifications on so you don't miss upcoming videos. Thank you for watching.